All right, I think we can go ahead and get started. I don't know if anybody else is going to join late, but we can
All
go
right.
ahead and get started. So this week's topic was prehab programs, and this was a continuation from the injury prevention efforts, which was the focus of the monthly the month. Oh my goodness, talking is hard. The March focus for the monthly topic was injury prevention efforts, and so we started with the preseason or the epidemiology and then the preseason screening. So really what you're looking for. And then now it's what do you do about it once you found it. So I'll go through my approach and how I program out prehab programs. And then we'll also go through a little bit of the literature and talk about what the evidence suggests in terms of what we can and can't do for injury prevention efforts. So general overview, the way that I think about it is the purpose of the prehab program is to address the insufficiencies that you found in your preseason screenings. And really what you're trying to do is reduce the physical strain or the risk of injury. So things that are at a greater likelihood of injury because either they have a decreased range of motion or they have some kind of a weakness, they have some kind of kinesthetic, postural, or movement deficiency that is going to open them up to a risk of injury. And then ultimately the activation, the preparation, and just getting the body ready to move for that day. So it's typically I like to grade forces, and I try to as best I can. They're coming in half asleep most of the time, so they show up early in the morning, and they are not at all ready physiologically to train. So what I try to do is get their body start really low force, really low output, and just kind of take them from basically laying down sleeping to up and running as fast as they possibly can. And you're really just trying to make that as smooth as possible. So what I usually do is I think about it in terms of like art. I don't know if you've ever seen a gradient, like what the one of the first exercises you do in like art classes is you take 10 boxes and you basically color the light. The first box is just completely white, and then the end box is completely black, and you take the 8 boxes in the middle and you're trying to grade them as smoothly as you can, and then you cover up the line in between to see if you can see a difference between those 2 boxes. When there's a line in between, it's pretty easy to see this one is white, this one is light gray. But if you cover that line, it gets a lot harder to see the difference between those two. And that's kind of the way that I conceptualize the prehab program. I want those exercises to be as seamless as possible. I want the transition between drills to be as smooth as possible so that there's no shock to the system that could open them up to an injury. I try to always pair the exercises with the deficiency. So, for example, if they have some kind of a range of motion issue, I'm not going to go out and then work on balance drills. Like I don't see the value in doing a stability drill, standing on an RX pad if they have a range of motion issue. So it has to make sense for whatever the deficiency is. So if it's a range of motion, I'm probably going to do some kind of stretching. Maybe it's some end positioning isometrics or some strength work, or maybe I'm working on joint mobilizations and trying to open up the joint range of motion as opposed to the soft tissue range of motion. But it's going to be some kind of movement where I'm trying to lengthen things out or open things up. I already talked about the grading of the activity levels. The last piece there that I want to talk about is going to be recognizing the priorities. So in a sports setting, the training is always the priority. The prehab can never supersede the training. And most of the time, the gym is also a priority over the prehab. There are instances where that's not the case, but for the most part, in order of importance, it goes training, then gym, then prehab. So you don't ever want to tax somebody so much in their prehab program that they go out and they have a terrible training session or they go in and have a terrible gym session. The prehab has to be facilitative. It has to help them have a better session or a better gym program. So never, typically I under aim or I undershoot what their prehab dosages are, and I'm trying to avoid fatigue so that they're getting just a touch of stimulus or they're getting a little bit of increased range of motion, but I'm not trying to cause so much that it's drastically reducing performance. Any questions about that so far, just with the overview?
Yeah. So, what are some things that you'd see in your exit physical that cues you into, all right, we need to do like a specific prehab for this athlete?
Yeah. So in a soccer specific context, the 2 most common things that we're going to see are going to be weaknesses of, let's say, the hamstrings and the adductors. So obviously in a professional setting, we are blessed enough to have the objective markers. So we use the Vault devices. That's not a paid promotion, but that's just, they're pretty popular. And so, for example, we can use like the Nord board and we can test the hamstring strength and we can see what are their hamstrings capable of producing across the range of motion. And so we would say, okay, maybe there's a huge asymmetry there that we don't like, and we want to reduce that asymmetry because that could pose an injury risk. Or maybe it's a just an overall strength issue, and maybe they're just really weak. They don't output enough force to protect themselves. So when they get out onto the field, they're exposed to these high forces. Do they have the capacity to protect themselves from those high forces? So it could be a range of motion issue. It could be maybe like a hip internal, external rotation issue. We see a lot of that with soccer players. Could be an ankle. A lot of times athletes come in with previous ankle instabilities and sprains, and this could decrease, let's call ankle dorsiflexion, for example. And we know what that does for the kinetic chain, right? Like a decreased ankle range of motion can send problems all the way up the kinetic chain to the knee, the hip, the low back, even to the neck. So the most common I would say that we're going to see are going to be range of motion issues or strength issues. You could potentially see some other deficiencies, but those I would say would be probably the most common. Actually, there's one more I would add into that would be a history of injury. So if they have some kind of a, let's call it a quadricep strain, then we know we have to go after that quad to protect them from a re-injury. We know that they're more likely to, or more susceptible to a re-injury once they've had one. So using their history to our advantage to then build out that program as well.
Gotcha. Yeah, that makes sense. So, for example, with the hamstring, if you noted an asymmetry with their exit physical, maybe spending more time doing like unilateral bridging, just stuff that's going to help prime that hamstring for their training session that day.
Yeah, you can go about it a couple different ways. I've typically I've come to adapt the increase both, and then that asymmetry decreases by the magnitude. So, for example, if you have let's say your left hamstring puts out 100 newtons and your right hamstring puts out 90 newtons, that's a 10% asymmetry right there. But if you have 10 Newton difference at 200, let's say 200 and 190, you're already down to a 5% asymmetry. So the just by raising the magnitude and the force output, the asymmetry shrinks. You don't necessarily need to go after the weaker side in order to reduce that. You can. I don't think there's necessarily anything wrong with that. Most people would, like, logically that makes sense, but you can reduce it by one of two ways. Either you raise, if you have an asymmetry like this, you can raise this one to match the other, or you can raise both, and now the asymmetry shrinks just because they're much stronger and they put out so much more force. So you can do it one of two ways, but I would say most commonly, especially in the professional setting, most people are going to push you toward elevating both as opposed to just trying to catch up.
Makes sense. Cool.
Okay, so in terms of addressing the insufficiencies, so again, making sure that the modality or the exercise prescription is matching what the insufficiency is. So if it's a range of motion issue, I'm going after the flexibility or the mobility. There's a company called Active Life, and they're really big on the difference between these two. Whether or not it actually makes that big of a difference, I don't necessarily think so, but I think it is kind of interesting to separate the two issues, because you could, for example, have they talk about in like the overhead shoulder range of motion. I can get actively, let's say I can get to here, but if I apply overpressure, I can get a little bit further. And so what they say is I have the flexibility to get to that full range of motion, but I don't have the active mobility to be able to do it on my own. And there's a little bit of a difference there, a nuance there in terms of the tissues that are at play. If it's an active tissue versus a passive issue, maybe I just need to increase the strength in order to be able to overcome that range of motion. And maybe it's a strength or a weakness issue that needs to be addressed. Or maybe it's a true, like, frozen shoulder example. It's a passive flexibility issue. You need to address the capsular limitation in order to get that shoulder range of motion back. So Could be caused by one of those two things, but if it's a range of motion issue, I'm not going to go out and try to increase their force production. For example, I'm not trying to put them on a force plate and see, oh, let's get them stronger because they've got a strength issue. So it has to match whatever the insufficiency is. If it's a strength issue, it could be probably categorized into one of two things. Either it's force production or force resistance. So can they produce the force in something concentric? This would be, in the case of testing purposes, it would be like a mid-thigh pull. And so it would be an overcoming isometric would be your method of testing. Or it could be a force resistance, doing something like a drop jump, or you could do like an isometric where they're adding something on top of it. So you're trying to resist the force that's trying to overcome you. So something like a wall sit with added weight. As soon as they put that added weight onto you, now you have to resist that increased force. Any questions about that?
That makes sense.
Cool. For the proprioception side, again, this is probably mostly going to be postural, depending on the nature of the sport. A lot of gymnastics training will train proprioception in different positions. They need to be much more in tune with their body because they're flipping through air and they're doing all kinds of different twists and flips. And their kinesthetic awareness just needs to be that much sharper compared to other sports and other athletes. For most athletes, what they actually need is the mind-muscle connection. They need to be able to feel different muscles activating and contracting so that they can properly sequence. So I was listening to a podcast with, I can't remember his name now, McMillan. He's the USA track guy. But anyway, he was talking about sequencing of the lower back and the lower extremity in running, and being able to contract the muscles in the order that you want them to, as opposed to the way they naturally do. Pretty interesting stuff, but basically the concept is having full control over the body as you're moving through space. For activation purposes, again, going back to the graded approach and trying to really just map out, starting with really low force production and then increasing that as you go. And you're only trying to get them so far. Like, I'm not trying to take somebody to a max deadlift before they go out into training. I'm trying to increase the force to the point where they're ready then to go out and warm up. So I don't want to overdo it with the activation. And it should be relative to the training demand. So in most soccer settings, they're separating training days into like high days or low days, or sometimes they call them intensive or extensive days. And basically what you should be doing there is trying to pair the muscles that are going to be used in that day or that context. So for an extensive day where you're going to be doing a lot more sprinting, you're probably going to want to increase the hamstring involvement, get the hamstrings ready for that demand. Where on an intensive day, you're going to do a little bit more change of direction, short cutting stuff. You probably need more adductor, or you probably need more quad activation, things like that. So the muscle that you're trying to activate should be appropriate for the training demands of that day. And that's going to change depending on the nature of the sport, depending on the position of the athlete, all of those different things. A goalkeeper, for example, is going to look a lot different than a field player. Midfielder is going to look a lot different than a forward or a winger. So it should all match. Everything should match, and it should make sense given the demands of that athlete. If you have, say, a regen day, if you have a re-entry day, and it's going to be a really short training session, not a lot of sprinting going on. It's more just like static, stationary, get the body moving, get recovered from that match day. Then your forces or your activation can be a lot smaller because you don't have to prepare them for such a high force output. They have to prepare them for, let's say, a 3-minute jog or something like that to recover. So again, it should be a graded approach and it should be increasing in intensity, but don't go past the point where it's necessary for that training session. Here's an example of what one of my prehabs looked like. So this was with an athlete who came in with quad tightness. So the first thing that I was doing is he was coming in and complaining of pain or soreness. And so the first thing we had him do is take a foam roller and work on the specific point of pain. And so it's really just trying to modulate that pain, trying to reduce it and make him feel better about moving. If he comes in cold and stiff, he's not going to want to move. That's universal for any athlete. They don't want to jump. They don't want to run. They don't want to cut. They don't want to do anything. So the first thing I have to do is reduce that pain to eliminate that barrier from the rest of the movement process. So after they do some kind of, usually with that A block, what I'm doing is some form of either stretching or foam rolling or bike ride if I just want to get their legs moving a little bit of warmed up. A lot of people will talk about blood flow, but really what I'm trying to do is just modulate pain and get them feeling better about moving. From there, moved into the knee extension isos. And so you can see 5 reps of 3 seconds. That's roughly 15 seconds of isometric contraction, 2 sets. So then they get 30 seconds total in that exercise. A really low dose. Like nobody's going to get fatigued from 30 seconds of isometric work. But it's supposed to be a self-guided intensity. And so they could start, let's say on their first set, maybe they do 50% contraction on that first effort. And so, okay, I'm coming in pretty cold and sore. I don't really want to push that hard. But then what they should be doing is they should be progressing from 50 to 60 to 70 to 80. And then maybe on their second set, they start at 80 and they go 80, 85, 90, 95, 100. And so it allows them to find that happy medium of I'm increasing the force output, but it's at my comfort level. I'm not rushed into it. I'm not thrown into it. I'm dictating whatever it is. From there, moved into the step up the knee drive. This is pretty much only a concentric action. Obviously, you have to step back down to reset, but it's not like a slow, controlled, eccentric movement. It's just dropping back down to the floor. So it's mostly a concentric action. He's not going to get a ton of fatigue. He's not going to get soreness from this, but it primes the nervous system to be moving a little bit quicker than something that's a stationary contraction like an isometric. So again, it's just gradating that force, grading that movement so that it's getting him ready to go. 2 by 6, again, who's getting maximally fatigued from 2 by 6? Nobody. So relatively low doses. The weights are self-selected for the prehab. Again, because I want them to do a weight that feels like it's getting them ready to train, as opposed to, oh, we need to get your quads a lot stronger, so let's make sure we dial up the weight. It's relative to their comfort. If they're really struggling, maybe they just do body weight. But if they're feeling a little bit better and they want to throw some weight on, go for it. Then move into the C block, which I typically use as a little bit more dynamic. And this is kind of that last preparation. Sometimes you can even do a D block if you want to, but I typically leave it to A, B, and C. And so the C block, I get to a little bit more explosive movement. You can add in some eccentrics here. You can add in some plyometrics, whatever that is that they need to work on. So he was struggling with decelerations. And so really working on what people would call absorbing force. Of course, there's no actual absorption of force. There's only production of force. But the ability to rapidly increase force production in that quad. So a drop lunge, unilateral, targeting that side that was bothered and not allowing him to compensate through the landing of the other side. I like both unilateral and bilateral for different reasons, but for him, it made sense to do the unilateral. So again, 2 sets of 5 on a drop lunge without weight. It's supposed to be max intensity. It's supposed to be max effort, but it's not high enough dosage and it's not a high enough intensity that he's ever going to get fatigued from it. It should just feel like he's getting his body loosened up and getting ready to move. And then the last one was the max effort, the linear bounds, and then landing with a stabilization. So it's a single leg, basically a broad jump, and jumping and landing. 3 reps as hard as they can, as far as they can, and they're stabilizing and landing. So it's going to be sub-maximal. A true max effort on this, they would be landing on their butt because they can't control the landing. Any questions about that?
Yeah, so just circling back to the last few slides, you had mentioned the difference between an overcoming and a different kind of isometric, and I've heard those terms before, but I was wondering if you could just explain the difference again and where you would put that in that ABC block.
Yeah. Isometrics would typically be a strength exercise. I suppose you could call it a pain modulation exercise and put it in the A block, but it's going to be low enough force and it's going to be no movement. So it's not very dynamic. It wouldn't be preparing them in that C block. So I would typically include it in that kind of middle phase. In terms of the 2 different categories, there's going to be overcoming, which you're trying to push and move an immovable object. So imagine doing like you put like 600 pounds on a bar and you're trying to bench press it, for example.
Hmm.
You're never going to, well, I shouldn't say that because there are people who can bench 600 pounds, but
But I've seen
uh,
an example of someone who'll do like a deadlift, and then they put like the bars so you can't lift it past the bars. That'd be an
right.
example of that, right?
Right. So underneath the pins, yeah, you can do it a bunch of different ways, but basically what you're trying to do is you're trying to move something that isn't going to move. You could do, like, for example, on a knee extension, you could put the weight all the way at the bottom to the point where they're not strong enough to overcome that weight, and their leg isn't going to move in that knee extension position. So that would be an overcoming ISO. And typically the purpose of that is to recruit motor units. You're trying to activate that muscle as much as possible. And um, you're trying to grade that according to their tolerance. A lot of times that's going to be limited by pain, because they're not going to, it's not so much force that they can't overcome it, because it's just whatever their body can produce.
Mhm.
If their body can't produce more force, then they just stop. So it's only limited by pain, really, and motor unit recruitment. So it's whatever they can tolerate. So again, maybe they come in the first rep they can only do 50%, and then after they tolerate that one, their body calms down a little bit, pain reduces, that pain threshold increases, and now they can start to kick at 60%. And it's just that gradual increase of motor unit recruitment without pain. So that would be overcoming. There's some, like, strength, I guess, like performance research in terms of like nervous system activation and being able to recruit more motor units, that it's beneficial for that. But from a medical perspective, it's really about pain modulation and being able to activate that tissue without having symptoms. The second one is called yielding isos. And so this would be basically trying to resist a force that is trying to crush you. So a wall sit is an easy example. That's probably the easiest one, even though it's not a true, like, nobody's ever falling to the floor because their legs give out from a wall sit. Like, it starts to burn, it starts to hurt, but nobody's like truly failing on a wall sit yielding iso. Now, if you add 400 pounds to a wall sit, now you're talking, okay, my legs might collapse underneath this, but it's just trying to resist that force. And the biggest benefit that I've seen with yielding isos is the application for tendinopathies. Basically, the muscle is trying to contract, but because it's so heavy, you can never move concentrically. So your only two options are going to be hold the position, or you're going to collapse and start to sink eccentrically. And so the muscles are trying to squeeze and contract, but they can't move anywhere. And so what ends up happening is the muscle stays tight, and then that creates the creep in the tendon, depending on the duration of it. So if you're holding a yielding iso for 10 seconds, there's probably not enough time there that the tendon is going to start to creep. But if you hold it for 30 plus seconds, now you start to get that tendon is really starting to lengthen out. And so with tendinopathies, you really want that tendon to be a little bit more mobile. You want that tendon creep to be therapeutic. And so long duration, heavy yielding isometrics can be really good for tendinopathies. There's a couple other instances where it can be beneficial. I would argue that for this kid who was doing he had the quad tightness, I would argue for him, doing some yielding long duration isos is probably a good thing. But in terms of like the research and what people are doing in the current practice, yielding isos are pretty good for tendinopathies.
That's
That
very
answer your
interesting. Yeah, for sure. And I like how there's a lot of carryover to PT as well with that kind of stuff. Because we see a lot
How
of
so?
tendinopathies. We see a lot of tendinopathies, specifically with patella, Achilles, the more common ones. And actually, an example of an overcoming isometric that I used today. I had someone who had neck pain after a motor vehicle accident. And so I just wanted to try to get them to activate the musculature around their neck without it being too painful. So to your point, that's a perfect way to use that because they're in complete control of how much force to produce. So
Right.
all I had them do was just get like a ball here against a wall and then just gently laterally flex into it. And it was very good. So that's a perfect example of that.
Mm-hmm. Yeah, like the self-limiting, especially for pain, like a lot of times we're saying, okay, well, only do it if it's below a 3 or a 4 out of 10, because that's what's been shown to be therapeutic. Uh, if you never did anything with pain, you're probably going to take forever in your rehab. So you have to push that boundary a little bit. and self-guided exposure to those different forces or positions is, I think, one of the best practices, because they dictate, it's on their terms. They can false report to us and say, oh, I didn't have any pain with that, but their body's going to tell them the truth. If they try to push any harder, they're going to stop because it's going to hurt.
Exactly.
So I think self-guided practices like that are a pretty good thing for most rehab or injury prevention efforts.
Totally agree. Especially when someone is in so much pain that any kind of concentric eccentric motion is going to be too painful. Isometrics are generally a really good place to start.
There's a book that I just finished. It's called Take Off by Daniel Bove, and he's a New Orleans Pelicans. I believe he's the director of performance there. And one of the chapters, he was actually saying that eccentric forces were one of the best places to start for that. Because isometrics have the potential to increase the force production over the concentric and eccentric. And it's an interesting argument, but yeah, I think most practitioners, at least in the medical side of things, are going to say, let's start with the isometric first, then build through the concentric, and then get to the eccentric, because the eccentric, they're always going to tolerate more force eccentrically than they can produce concentrically. That's just like laws of physics.
Right. Cool.
All right. So that was the example of one of my prehabs. For the literature review, there's some decent writing. The Prehab guys has obviously their whole blog post series. Their whole company or business is dedicated to prehab programs, whether that is pre-surgical prehab or if it's just injury prevention or like warm up, getting ready for physical activity. So they've got a lot of interesting content on there. Not all of it, I would say, is up to par. Some of it's kind of subpar quality, but there's a lot of good resources if you just look for it. You might have to skim through a few articles in order to find one that you like, but there is some good content on there. And then there's another article that was a really long editorial piece that was it's on this guy's website. I can't remember the exact title of the website, but the Why Prehab link there has a really long explanation of the benefits of prehab programs. RP hypertrophy, I'm a big fan of. Dr. Mike, and he has a YouTube short. I think it's like 20 seconds long if you want to watch that one. And he explains if he thinks that lifting's preventing injuries. And then also he's featured on the Coach 'em Up podcast, where they talk about injury prevention for athletes specifically, and talk about injury prevention efforts and strength and conditioning, and how all of those different gradation of forces kind of intermingle. So really interesting. I think the Coach 'em Up podcast is awesome. But then also, like, they featured Dr. Mike, which I think he's awesome as well. So the combination of those two makes for a really entertaining podcast, but also really good educational podcast for prehab purposes or injury prevention efforts. Last week, I was talking about Buddy Morris, and he talks about his thoughts on injury prevention. And he's got a really good quote where he's saying, he says injury prevention is fake news. Basically, he says, if you want to prevent injuries, stay on the bench. Never play sports, because if you play sports, you're opening yourself up to a risk of injury. So no matter what we do in the gym, no matter what we do in the table, these guys go out and things happen. That's just the nature of sports. It's a chaotic environment. So you can never prevent. I'm in the same camp. I don't believe you can really prevent any injuries in 100%. For this week's publication review, the topic or the theme of the paper was they did a systematic review first, and then they followed up with a meta-analysis. And they were just reviewing the information and literature that was produced previously, randomized control trials for injury prevention programs. And this included a wide range of topics, external supports like bracing and taping, different arch supports or insoles, different types of shoes for injury prevention purposes. They talked about like high top versus low top for basketball. And then they get into the more intrinsic measurements, the training programs, stretching, all those kinds of things. So really interesting deep dive into the literature. This was published back in 2014, but the kind of things that they were already seeing to be effective or ineffective, and especially through a more broad picture of a meta-analysis. This was pretty insightful, I think. What they found was for the effective injury prevention efforts, the highest odds ratio was the external joint supports, and they talked about the two most common, I believe, were for the wrist and for the knee. For the ankle, it did reduce the number of injuries, but it wasn't as significant or as impactful as the wrist and the knee. I wish they would have clarified within the like wrist, which sport specifically are they talking about? Is it a wrist support for, I would assume not for like boxing or something like that, maybe baseball, or for something like weightlifting, powerlifting? Is it like wrist straps? Because I could see like in CrossFit, that's going to definitely reduce number of injuries. Versus something like a knee brace for an offensive lineman. We talked a little bit about that, but it really, it's great because it shows that these things work, but it's not quite as specific as we need it to be to apply in our clinical practice. Insoles, for example, reduce the number of injuries significantly, cut it in half compared to the control group, but they don't specify, is this relevant for soccer players? Is this relevant for runners, like distance runners? Is this relevant for American football players, baseball players? Who specifically is benefiting from the modification of the insoles in their shoes? But they did also show that specific training programs and weightlifting, gearing up for the demands of the sport, were also effective. Specifically with the hamstring, they were talking about the Askling papers and protocol, and found that the hamstring strengthening programs were effective in reducing hamstring strains. So interesting, because there's not quite a lot of, there's way more research on hamstrings than there is any other soft tissue injury. I think that the adductor is probably going to catch up to it, because I think a lot of people are going to start to research the effectiveness of adductor injury prevention programs as much as they do with hamstrings, just because of the time loss across sport. The hamstrings dominate in any sport where there's sprinting involved. So I think adductor will catch up to it eventually, but right now the research efforts are definitely there for hamstring. So for the specific training programs, that was one of the things they discussed. And then I can't remember the other one off the top of my head, but there was a couple that were in the paper specifically for strength and conditioning programs. For the ineffective side of things, they found stretching to be statistically insignificant, although I will say if you look at the odds ratio, it tells you it's slightly better than a control. So the argument I always make is it's definitely not hurting to stretch. The question that I would always pitch for stretching is I think the devil is in the details. One, how long are they stretching? And two, who is stretching? I think like when I worked with track and field, my argument was always stretching a normal, healthy person is never going to prevent injuries because they don't have problems with tightness or immobility. But if you take somebody with tightness and immobility, lack of range of motion at the hip, what happens to the demands in the hamstring? It goes up, right? So if you stretch them, you get them more mobile in the hip. Now you start to take the demand off of the hamstrings. You should see less injuries. But according to this, statistically, it's insignificant. So the other thing is in the details would be how long are they stretching? I posted on my Instagram story a while back, and they found the duration and the intensity for stretching tends to be way too low to produce any kind of structural changes. So if you truly want to increase the muscle length, what you have to do is you have to hold a really long duration, usually in excess of 1 minute. So how many people do you know that are holding a really intense stretch for a minute? Nobody's doing that. They're doing like 5-10 seconds and they say, okay, I'm ready to go. That is never going to do anything. You might decrease you might modulate pain by doing that. So a 5-10 second stretch might be sufficient to get somebody like moving. But in terms of injury prevention and true structural changes, you probably have to hold it for like a minute plus, maybe even 2 minutes. And it should be painful. That should be your cue for the intensity. It should feel like you're changing the musculature, just like in the gym. If you're doing 5-pound bench press, yeah, you're never going to get stronger. But if you throw on 200-300 pounds and now it feels heavy as crap, yeah, now you're going to get stronger. So again, I think that the stretching gets a bad rap because people see studies like this and they say, oh, it doesn't reduce injuries, so why would I waste my time on it? Well, yeah, but like, who is it good for? Who's it bad for? And then how are they stretching? Are they stretching sufficiently? Probably not. So I always advocate for stretching, even though the research doesn't support it. Modified shoes, again, they talked about changing from high top to low top. I believe they changed in a couple of different sports, but what they found with basketball was that it definitely doesn't reduce the risk of injury, and in some cases it actually increases the risk of injury. So the modified shoes doesn't seem to be a sufficient injury prevention program. And then the last one was the preventive videos. The biggest example they gave here was for skiing and giving documentation for how to ski. And they found that to be ineffective as well. But again, I would say, well, you're on the right trend. It's just not statistically significant. Like 0.86 odds ratio shows you that it's better than a control. So if I'm in a clinical context or in a clinical setting, and I have to decide if I want to show somebody these preventive videos, I would say, yeah, it's better than not showing them. Like, it might not be statistically significant, but if I can reduce 14 out of 100 injuries, yeah, it's probably worth it. So I think that you have to take the findings with a bit of a grain of salt. It might say it's statistically insignificant, but if you're trending in the right direction, does it hurt to do it? Probably not. Any questions about that?
So for the stretching, did they specify if it was like a dynamic warm-up type of a stretching prior to exercise, or was this like a static stretching that's done in junction with like a strength program?
It was static stretching specifically for that paper. Most papers show that for injury prevention efforts, that dynamic tends to be better for injury prevention program. But you're comparing, like, okay, again, like you're comparing somebody who's going to do a 10-second static stretch and then go out and play a full like Sunday league soccer game, as opposed to doing like a 30-minute warm-up program. Like, which one, common sense, like, will tell you which one's going to prevent the injuries better. But if you're trying to truly increase the muscle like architecture, then you need long duration, high intensity, like painful stretches in order to change the musculature enough to have injury prevention effects.
Gotcha. Yeah, that makes sense.
But yeah, that I can send you that study if you're interested in it. It was reviewing the intensity and the duration of static stretching for reducing injury efforts.
Perfect.
So that wraps up this week for prehab programs. The way that I conceptualize it, and this isn't backed by any research or evidence, but this is just the way that my brain kind of makes sense of it, is to address the insufficiencies that you found in the preseason screening or through the epidemiology. If you know that your population is susceptible to some specific type of injury, then you want to make the effort to try to reduce those things. So again, maybe they don't have any red flags on the entrance exams, but you know that their sport opens them up to adductor injury or hamstring injury. So you want to try to reduce the likelihood of those things. If it's a range of motion thing, you should be pairing it with range of motion exercises or exercises that improve range of motion. If it's a strength or a weakness issue, then you want to be pairing it with things that are going to improve their strength. If it's a proprioception, then you want to do exercises that challenge proprioception. And if it's activation issue, then you just need to grade that activity and get their body ready to move. I already said that part. The activity should always be graded. That goes for not only for the strength and the force output, but also for the stretching. So if you come in and you just cold stretch, it's probably not going to feel great. But if you have them bike for 10 minutes and get their legs moving first, then that stretching intensity can be graded. For the priorities, never do too much in the prehab and err on the side of doing less, because you would rather have somebody maybe a little bit cold or a little bit stiff going out into the team's warm-up, as opposed to being exhausted and then they have a terrible training session or a terrible gym session. Avoid fatigue, and then you can microdose some of those things throughout the week to make sure that they get enough volume. You don't have to throw it all into one session. You can space it out across 3, 4, or 5 sessions. Any last minute questions about that?
No, sir. That was very informative, and like I said, I like the crossover into the PT side of things, so I can actually try to apply some of these things into my to the
Awesome. Yeah, let me know if you have any other questions, or if you're making prehab programs for anybody that you're working with, and if you want me to take a look over it, I can definitely give you my 2 cents. I don't claim to be an expert, but if I can help in any way, just let me know.
Perfect. Yeah, I appreciate it, man.
Next week is going to be the gym adaptation. So we'll talk a little bit more about if we're trying to increase strength or if we're trying to increase the stretching and the muscle length, how you can go about it, and the different kind of strategies to target those different adaptations that we might want. Maybe that's a strength issue, or maybe it's an endurance issue. How do you go about tackling those different insufficiencies? So keeping with the injury prevention efforts, these are the specific adaptations that we're targeting. How do we go about getting them?
Awesome. Yeah, I love this kind of stuff. This is what's really interesting to me, so I'm looking forward to it.
Awesome. Thank you for being here, and we will see you next week.